it's my pleasure to address this question. Do we need ARDS? And my answer will be yes and no. We could start by defining ARDS, and you may say it's a form of acute respiratory failure with a PF ratio. No, these are criteria. We often confuse definition and criteria. If I speak about a myocardial infarction, the definition will not change over time, but the criteria may change over time. ARDS is a form of acute respiratory failure due to non-hemodynamic pulmonary edema. So the criteria may change over time, exactly as for sepsis. Sepsis has always been sepsis, but you could argue that we can quantify the degree of organ dysfunction. Or shock is acute circulatory failure, and there are criteria for it. So we called our new consensus definitions, we call them definitions, but they were not definitions. They were criteria. It's not a Berlin definition. ARDS was already defined and remained the same. The criteria changed over time. I was part of the process. I'm not criticizing. I'm just telling that changing the criteria was necessary, but we have not changed ARDS. Now, ARDS can be due to several diseases, as we know, and so it is just a syndrome after all. And it's not an illness. And that's the point. It is, by definition, heterogeneous. Now, in this excellent study by Dr. Bellani and others, the lung-safe investigators, it was shown that clinicians do not always recognize ARDS in hardly more than 50% of the mild cases. And people say, oh, that's very bad. How could ICU doctors not identify ARDS? My question is, so what? Once you have put the label ARDS, what are the implications in terms of respiratory management? Oh, yeah, we need to limit tidal volumes because we have learned 20 years ago that large tidal volumes can be harmful. I agree, but it has been shown since then that it's the case in other forms of respiratory failure, or actually, whenever a patient is mechanically ventilated, we need to limit the tidal volume. And we can say that critically ill patients without ARDS should receive ventilation with low tidal volume, low FiO2, spontaneous breathing activity, and a restrictive strategy of sedation. Very important. Some people forget the sedation aspects, but okay, that's not my talk today. So there is always a risk of VILI, of ventilator-induced lung injury, if we use excessive tidal volumes. We have put the label ARDS. In terms of pharmacologic management, we have not been very good. Maybe corticosteroids in severe cases, because there is a lot of inflammation in the lungs, but that's about it. Ideally, we should develop drugs that could afford endothelial protection, better anti-inflammatory agents with less secondary effects than corticosteroids. But again, for a syndrome, there is no specific treatment. You may say, oh, fluid management, there is a lot of fluids in the lung. That's lung edema, right? I agree, but be careful about diuretic administration. because diuretics are the opposite of fluid challenge, right? So they may decrease cardiac output. Diuretics do not increase cardiac output. By the Frank-Starling mechanism, they can only decrease it. And remember this very important study done a number of years ago showing that with conservative fluid strategy, the duration of mechanical ventilation can be shorter, okay? But look at the follow-up study. In the follow-up study, where people had sometimes a problem of cognitive disorders, this was particularly present in patients who had a conservative fluid management and probably a lower cardiac output with this conservative fluid management. So let's be careful. We need to respect the various phases of the resuscitation, salvage, optimization, stabilization, de-escalation, and diuretics should not be given in the early stage. They should be given when we are sure that the patient is stabilized. In COVID-19, it was a problem. People discussed, is it ARDS? Is it the same as in non-COVID patients? Well, it cannot be ARDS because the respiratory failure develops more than 1 week after the onset of the symptoms. But okay, that's semantics. Okay. But we know that there can be a viral pneumonia. It's not ARDS from the very beginning. So indeed, thoracopulmonary compliance may not be very low initially. And that's how Gattinoni spoke about the type 1 and type 2 respiratory failure in COVID-19. Okay, it's not always ARDS. But when it is ARDS, we could discuss, is it the same as in non-COVID patients, yes or no? Okay, we can speak about it for a while. But does it matter? If we individualize our therapies, does it really matter? I was very pleased to be involved in this publication, but I'm not so sure that it will result in significant implications. You may say we should not use an excessive PEEP level. That's okay, I agree, we should never use excessive PEEP level. So ARDS, again, is a syndrome. You may say, what about pathologic alterations? Aha! There should be diffuse alveolar damage. That's the signature. That's the characteristic of ARDS, right? Okay, but at autopsy, as indicated already by Andres Esteban many years ago, you don't always find diffuse alveolar damage, DAD. With Dr. De Hemten, we published this paper many years ago. Exactly 1/2 of our patients with ARDS had the diffuse alveolar damage at autopsy. 1/2. And later on, Dr. Tille, in a large number of patients, found exactly the same. 1/2 of patients with ARDS have the diffuse alveolar damage. So, sorry, but even at autopsy, you cannot say that it's becoming a disease. So, what are we supposed to do? We should always limit tidal volumes. We should always use some PEEP to avoid high FiO2s. We should always consider the patient positioning, put the patient in prone positioning when hypoxemia is severe. We should always avoid fluid overload. So, putting the label ARDS does not have major implications. For the last minutes, I'd like now to say that I like to use the acronym ARDS, because when I make rounds in the intensive care unit, and when you present to me a patient with sepsis or a patient with ARDS, I know what we will speak about. If you speak about ARDS, I know it's a severe situation, and I know there are some common aspects in the management of these patients. In terms of fluid management, of course, we must be particularly careful to avoid excessive fluid administration with fluid overload. But do we need ARDS? Well, yeah, first, it's severe. If you present me a case of ARDS, I know it's severe. This patient should be in the ICU, and we should pay particular attention to this patient. But then there is a yin and yang. If you identify ARDS and if you look for a cause, that's very good. If you identify it, but then you play with the knobs and you discuss the management of ARDS, but if you do not look for a cause, that could be dramatic. Of course, in COVID-19, we have the cause, but in other cases, when it's the heterogeneous syndrome, we need to look for a cause. And this will help to define the situation a bit better. We should go from poorly characterized patient populations in our trials into personalized medicine and precision medicine. And that's where we are. We can start to identify inflammatory states associated with ARDS versus non-inflamed situation. Look at the simvastatin study in ARDS. No effect on survival. But Dr. Calfee and collaborators did a very nice study looking at a number of variables identifying subphenotypes which are hypoinflammatory or hyperinflammatory. And the hyperinflammatory subphenotype may benefit from statins more than the other subtypes. With fluids as well, Dr. Famous and together with Dr. Calfee and others found the same thing, that perhaps there are some patients who may benefit more from fluids and patients who may benefit less from fluids. It was still an initial approach because the investigators realized that they had mixed up the two groups. And they said, sorry, but we inadvertently exchanged the two groups. The group A was the group B, the group B was the group A. Okay. But more recently, Dr. Calfee and collaborators presented this very nice study looking at phenotypes from various prospective randomized controlled trials on the ARDS. And as you can see, simple variables like bicarbonate, the need for vasopressors, creatinine, etc., could help to identify the right treatment for the right patient. It was primarily laboratory variables, but so-called vital signs could help. And they found that in the hyperinflammatory phenotypes, fluid administration could result in a lower mortality rate, whereas in hypoinflammatory states, it could be better. And for the PEEP level, it's the other way around. In hypoinflammatory phenotype, it's better to have a low PEEP. In hyperinflammatory states, it's better to use a high PEEP. So that's the future. We need a better patient identification. That's how we will make progress. That's how we will identify the patients who could benefit from corticosteroids and from other interventions. So with Professor Slutsky, we recently published this paper where we said we have never seen a patient with ARDS. We have seen many patients who could meet the criteria for the syndrome, and we therefore knew they had non-hemodynamic type of lung edema, an acute edema due to something else than left heart failure, but we try to find the cause and we try to identify the phenotype to have a personalized therapy. ARDS should not prevent us from applying a personalized therapy. We have never seen a patient with ARDS. So I'll stop here. Thank you very much indeed.